There you go. Okay, roll.
Okay, perfect. All right, thank you for that. Sorry for that delay there. So my name is Benjamin, and I have the opportunity to talk to you today about the challenges that I think we still face as clinicians in treating heparin-induced thrombocytopenia, or HIT. Now, HIT, as many of you know, is this rare adverse reaction to heparin, and it begins with the binding of heparin to PF4, which are these chemokine proteins that are released by activated platelets. Now, what's more important, though, is that this binding generates a new epitope, which could be recognized by the immune system. And in some patients, it leads to the development of pathological anti-PF4 heparin antibodies. They're pathological because they can bind platelets and activate them, causing them to aggregate, and also to release prothrombotic microparticles. These antibodies also bind monocytes and neutrophils, activating those cells respectively. But what we see on the clinical side is we see, first of all, thrombocytopenia, and the platelet drop usually happens in a very fixed time span between day 5 and 10 of exposure to heparin. The drop is usually about 50%, and the nadir count of platelet is usually above 20 giga per liter. Now, these patients become exquisitely prothrombotic. In fact, this is one of the most hypercoagulable states known to medicine. Just to give you some statistics behind HIT, we know that HIT occurs in roughly 1 in 1,500 admissions, and the incidence is highest among surgical patients, especially orthopedic surgery patients, as compared to medical inpatients. We also know that the type of heparin matters, because unfractionated heparin, with its long polyanion tails, are much more HIT-genic compared to low molecular weight heparin. Now, I mentioned earlier that it's very prothrombotic, and indeed, if you look at the rates of thrombosis, you'll see that 50% of patients will have a blood clot at time of diagnosis of HIT, and or without treatment in the first 30 days of diagnosis. So that leads me to the first challenge facing clinicians in treating HIT, and that's picking a alternative anticoagulant. Now, you might be wondering about warfarin, but I think many of you realize that warfarin can actually worsen the prothrombotic milieu, at least in the upfront setting, before the platelets recover back up to 150, its normal range. So clinicians often use alternative agents such as argatroban or fondaparinux or DOACs. And I'm showing you here the efficacy data in decreasing thrombotic rates based on systematic reviews as well as meta-analysis for the first two. And then in the DOACs, it's a much newer experience that we have with this in the last 2 or 3 years, and it's based on McMaster's data of about 70 patients collected in the series. I think the biggest problem here is if you look carefully, the data is actually not very robust. Certainly, we lack large, well-controlled head-to-head RCTs. Most of these studies are retrospective. And most problematic, I think, is the argatroban data, which are about 2 decades old now. Because if you look at the inclusion criteria of those studies, you realize that they do not meet the modern rigorous standards of the definition of HIT. So a lot of those patients probably had thrombocytopenia, but many of them probably did not have HIT. And fondaparinux, the data is a little bit better, but again, all retrospective. And the DOACs, it's from these patient series, and you always run the risk of publication bias. So what I'm trying to drive home is that, yes, there are these alternative agents available to us, but we are using them not really knowing their true kind of efficacy and if one is really better than the other. Turning your attention now to another area of HIT, this entity that has been coined autoimmune HIT. It's actually an umbrella term, and it includes persistent HIT, delayed onset, spontaneous HIT. These are described in the last 3 or 4 years or so. And they're united by this pathophysiology where the anti-PF4 antibody no longer requires heparin to activate platelets. I'm going to let that sink in. That means we're seeing patients who have never been exposed to heparin, and they drop their platelets, they get thromboses, and they actually test positive when you look for the serology confirmation of these antibodies. Or there could be patients who were started on heparin, but the heparin is shut off, and yet they continue to be thrombocytopenic, and they continue to thrombose. So very difficult to manage population, but luckily in the last 2 or 3 years or so, Dr. Workenton and Dr. Greinacher have published their experience on using IVIG, which seems to be very efficacious in shutting off this runaway reaction. So I think the challenge nowadays is in recognizing these entities, because they're so rare, but recognizing them early enough to treat them properly. And just in the last minute, I want to touch on our experience in terms of HIT in cancer patients. This is a very poorly studied population in literature. We looked retrospectively at 95 HIT patients that were treated in a 10-year span in our institution. We actually saw that 40% of these patients had a concurrent diagnosis of cancer, and most of them turned out to be GI cancers. But what's more interesting to me is that we actually observed about a quarter of them having myeloproliferative neoplasm. You can imagine that these patients had a higher platelet count at baseline and even at nadir. In fact, their median nadir is 100. So I wonder if we're actually missing a lot of MPN patients because we're not paying close enough attention to the thrombocytopenia. Regardless, on the whole, these patients do poorly because even on treatment, and this is with argatropan or fondaparinux or a few cases of DOAC, 18% sustained the clot, 10% had major bleeding, and 15% died in the 6-month follow-up period. So, at this point you might think, well, there is that competing risk of cancer to drive these outcomes as well. But I'll point you to the fact that in patients who have cancer-associated thrombosis, if you put them on treatment, their recurrence rate is much lower than what we're seeing. It's usually in the range of 6 to 8% or so, not 18%. So I think the drive home point is that this is a poorly understood area and they do poorly, and we definitely need to pay close attention in the clinical setting and to pursue more research in this area. So with that, I'm going to end my talk and I'm hand it over to Dr. Conway.
Thanks, Ben. Can you just unshare, please? Thanks. And I'm going to introduce our next speaker, who is, but I'm going to introduce you, Judith. So hang on for 1 second, because this is Dr. Judith Hall is going to give a talk about her experiences with HIT. But Judith completed her medical school training at Earl Davie's alma mater, the University of Washington, followed by a Master of Science in Genetics and training in pediatrics at Johns Hopkins. She then took on leading roles as a research scientist and professor of medical genetics at UBC and BC Children's Hospital, where her work has profoundly impacted on our knowledge of genetic diseases and disease processes. Her story is really beautifully recounted on the website of the Canadian Medical Hall of Fame, where she is recognized as a laureate. But Judith is not here for that purpose. Today she's a patient, and she has kindly offered to tell her story. So Judith, thank you for coming, and we look forward to your story.
Okay.
Now you're here.
Well, thank you for asking me, and I'm really very honored. And as you pointed out, Earl was one of my teachers at the University of Washington, as was Dr. Fisher. I'm a clinical geneticist, and so I'm very aware of my family history, and there are 27 different disorders. I don't have them all, but I was aware that aortic stenosis seemed to be an autosomal dominant in my family. Both my father and my brother had it, and so when I was diagnosed at 65, I wasn't surprised, and I was doing fairly well and really didn't need surgery until I was 77. And it's a little more complicated than that because both my father and my brother died post-surgery. So I sort of thought there must be something going on. Never heard of HIT, but I thought it was an arrhythmia. So I had every possible test for genetic arrhythmias, and they all came back fine. And so no worries, I went to surgery, and in fact, everything went beautifully. No problems. I got to go home at 6 days, but exactly 10 days after surgery, I woke up in the morning and could not breathe. And it was really scary. And so my daughter, who was still there taking care of me, said, shall I call 911? And I thought, no. Yeah, I can't breathe. Well, I don't know if you've ever called 911, but I never had before. And there's a fire station very close to my house. So instantly I heard the siren. And those guys were there in 3 minutes, and they gave me oxygen, and I could breathe. Well, you thought, oh gosh, is this a false alarm? Well, pretty soon the medics get there, and they do an EKG, and they say, you've had a pulmonary embolus. And I thought, no. I'm a pediatrician, but I know you're supposed to have pain, sudden onset with a pulmonary embolus. Well, okay. So we get in the ambulance and go to Vancouver Hospital. And the way it works is that the medics stay with you until there's a disposition. So I'm with these lovely medics, and about 15 minutes later, an intern comes out with my chart from my heart surgery and says, the last day you were in the hospital, your platelets were low. I think you have HIT. Well, I'd never heard of HIT, but they whooped me into the CAT scan machine. And sure enough, both lungs and right side of my heart are completely filled with emboli. So that's kind of the last thing I remember for the next week, because I'm sedated, go to the ICU, and I don't know what happened there, but they sure took good care of me because I didn't have a stroke and I didn't lose a limb. And I realize I am really, really very fortunate. So I wake up on my way to the ward and get trundled into bed and get superb care from the hematology group, the hospital. But, and I learn a lot about what HIT is, but my platelets are not very cooperative. Now, of course, probably most of you have not been patients, but it is really boring on the ward. And so I got my friends and staff and people to bring me everything they could find on HIT. So for the next 6 weeks, I think it was that long, I'm reading about HIT, learning a lot, and just kind of blown away because I'm a pretty bad case. My platelets stay down there at 20,000. And finally, I think this is what happened. I said to Dr. Chen, why don't you call Workney? He's Canadian. He said, yeah, McMaster. He may be able to suggest something. And apparently he, thankfully, suggested IVIG, and it was a miracle. Literally, overnight, my platelets went from 20,000 to 200,000. And in some ways, it just never looked back. I mean, I stayed around for a couple of days just to make sure it was okay. But I am unbelievably grateful to the hematology group, to Dr. Chen, to the hospital. I mean, I feel like I got really, really good care. Well, there's another happy story, and that is that 6 months later, Dr. Workney actually wrote a letter to the New England Journal so the world could become aware of the use of IVIG. And I felt really grateful. So I wrote him and said, thank you. Well, he wrote back and said, I'm coming to Vancouver for a meeting in a month, and it'd be nice to meet you. So I had the pleasure of getting to take him out to dinner, he and his wife, and show them around Vancouver and tell him thank you properly. So there's an element about telling this story that makes me think back 4 years ago, and that I might not be here. I might not be alive. I mean, I am so profoundly fortunate. And so when I think about what's happened over the last 4 years, I've gotten to have a family reunion. I've gotten to take my grandchildren on their 13th birthday tour with grandma to wherever they wanted to go. I've published 25 papers, including a symposium on my favorite disease. I mean, really, I'm here because of scientific project. And I feel unbelievably grateful to the hematology team, to all the research. And it reminds me how progress really is made. And thank you to all of you hematologists, and thank you for inviting me today.
Thank you so much, Judith. Ben, do you want to jump in here? Can't see you. We have lots of clapping here. Are there any questions of Judith or of Ben? We have a couple of minutes. Ben, do you want to make any comments about Judith's course? Or do we dare? Or anybody else? We have lots of heparin hit experts probably in the crowd. Anyway, it's really wonderful to hear the experiences of our patients living through these things, not to mention it reinforces the importance and the value of our research. Ed Chrystal, I can see tuning in.
Well, maybe Donnie, maybe Ben will be able to give us a better picture of how IVIG is working here. Yeah, so I mean, that's probably the question that at least half of the audience is wondering.
So I don't know, Ben, you may be able to give a proper explanation, but at the time I remember they're saying, we don't know how it works, but IVIG goes around and sort of sops up all the antibodies.
Yeah, it's thought to sort of go around and actually mop up, the Fc receptors and prevent the binding of these pathological antibodies to their target cells, the platelets, the immune cells. So, but you know, this is such a new concept. I think there's a lot of work that still left to be done to elucidate these exact mechanisms.
I wish Alan Lazarus was. I wish Alan Lazarus was here. He would set us straight, right?
Donnie, do you want to jump in for a second on that one?
Well, I'll just say, Dr. Hall, it's a pleasure to have listened to your talk. And I am fortunate enough to work very closely with the illustrious Dr. Ted Workington. And he is just an amazing, we call him an observational clinician, in that he will dissect out each case so that he gets right to the bottom of things. So anyways, I'm sure I'll pass on that we had this common symposium today. He'll be very happy. Ed, I don't know that I have the answer about why IVIG works in HIT. It's so new but it does look like there's a really important effect, especially in the most severe cases. And then maybe it's as simple as swamping the Fc receptors and not allowing those to be available for platelet activation, et cetera. But we just don't know. And you're right, Alan would tell you that there are 4 or 5 other mechanisms that we're not even considering that are probably important related to downstream effects. So don't know, but amazing observations.
Thanks, Donnie. And you know, Judith, I'm not going to applaud. I'm just going to wipe my eye. Wonderful to have you here.
Well, my pleasure to be alive, I'll tell you.
Great. Okay, well, thank you all of you for participating and for being here. It was excellent. All right. So we have another speaker now who is also a patient, and we really value having patient participation at these symposia. It gives us a perspective that we often miss. And this is Chrystal Gellein. Is that how you pronounce it, Chrystal? And you have to unmute yourself.
Yeah, Gellein, yeah.
Gellein,
Very
okay.
close. It's Norwegian.
Norwegian, okay, so my Norwegian is lacking. But Chrystal is going to give us a story, a different hematologic disorder that is common enough that you will all be reasonably familiar. So Chrystal, the floor is yours, please.
Okay, good afternoon and hello, and thank you for inviting me to talk today. My name is Chrystal Gellein, and I'm going to tell you my ITP story. I was growing up, I grew up in Quesnel, BC, a northern town. I enjoyed many outdoor activities that the north offers, skiing, skating. But in my teens, I began to see huge dark bruises on my body. I went to my doctor, and the results from a blood test were that my platelets at that time were 50. So he put me on prednisone. It helped at first, bringing my platelets to over 150, but soon I became steroid dependent and kept needing higher doses of prednisone. And in 1991, I had a bone marrow biopsy to rule out any cancers. I was 18 at this time. This left me with a diagnosis of ITP. I was then referred to a wonderful hematologist in Vancouver, Dr. Linda Vickers, who would go on to be my hematologist for 22 years. And she was very dear to my heart. She mentioned other medications that I could go on or have the option of having my spleen taken out, a splenectomy. My parents and I, we had to make some decisions. And at this point, I had already been on 100 milligrams of prednisone a day and was suffering from a long list of side effects. I was no longer able to work because of these, and I had to go on medical leave from my job in an accounting office. My platelets eventually dropped to 10, and so we decided that I would have my spleen out. At this time, I was kind of tired of the medications. And in January 1992, my parents then took me it was an 8-hour drive from Quesnel to St. Paul's Hospital in Vancouver. And my platelets were around 30 at this time. But while being in the hospital waiting for surgery, they actually went to 7. And for me, there was also another major issue to consider. And I am one of Jehovah's Witnesses, and then would not receive transfusions of any blood products. This is because of a command in the Bible which says to keep abstaining from blood. And I had told Dr. Vickers about my beliefs in the first visit, and she was very respectful and was considerate. And so the day before surgery on the Thursday, the surgeon and the anesthesiologist, they came in and they reiterated to me how serious the surgery was. I realized what it was. And then they confirmed that my decision to not have a blood transfusion. And then in Friday morning, I was off to surgery. All seemed like that it had gone well after the surgery. But in recovery, my blood pressure became low, and the doctors thought that I was having internal bleeding. So I was rolled into surgery for a second time in the night, Friday night. My only conscious memory was that the surgeon, Dr. Pang, who did an excellent job all in all, asked me if I would still now, if I would take a blood transfusion at this time. And my answer and conviction was still to say no. As it turned out, when Dr. Pang opened me up, he found that I had a little part of internal bleeding still. And so he went in and he fixed that. My hemoglobin after surgery was 5, and my platelets went to over 900. So that was a drastic change in the platelet level. And Dr. Vickers, then she visited me the next day, and she was surprised. I remember the look on her face, just so surprised to see me actually sitting up in bed, and I was smiling. I had a very good recovery going forward after that. She did put me on erythromycin and iron pills to help build up my blood. But as the previous speaker spoke about, I'm very thankful to have life after that situation. It could have been very scary and was scary for my parents too. Anyhow, as it turned out, on to the next one, sorry. So 2 weeks after surgery, which we had planned to move before my surgery, we actually made a move to Campbell River, Vancouver Island. And I married a wonderful man a year later in 1993. And for the next 23 years, my platelets stayed between 40 and 80. And so for me, that was my normal. They fell more when I would get a virus, and a burst of prednisone of 50 milligrams a day for 5 days helped that. And then in 1998, I became pregnant with my daughter. And Dr. Vickers, she found an excellent obstetrician from St. Paul's Hospital to follow me through. And during the pregnancy, though, I got the flu, and my platelets fell to 3. And so I started on prednisone immediately, and this kept my platelets to a safe level through the pregnancy. My daughter, she was born by cesarean on April 30th, and her platelets at birth were very low too. They actually bottomed out at 15 for her. So she received IVIG, and her platelets went up. and no looking back. She's never had a problem with that since. So I'm very thankful for that for her. In 2012, I needed to have my gallbladder out. And so I reached out to Providence Hematology again. And sadly, to my dismay, Dr. Vickers had closed her practice for medical reasons. That was difficult for me, but I went on to meet another excellent hematologist, Dr. Camilla Ross. And with her assistance, I was able to get approval through compassionate care for a medication fairly new, I think at that time, Eltrombopag. And well, for me, that is the medication that I need and is the medication of choice for me. My platelets, they rose to normal, and I didn't really have side effects personally for me. And I was able to have my gallbladder out with no problems at all. But I was only approved for Eltrombopag for 6 months to get through the surgery. And then in 2014, my platelets crashed, probably from getting so many viruses from working in childcare. I had to retire from childcare, which I love dearly. I have done it 20 years of childcare. And then working with Dr. Ross, I tried different courses of treatment. I went on hydrosprednisone again, rituximab, mycophenolate, and azathioprine. The only thing that works temporarily for me for now, when my platelets go really low, is IVIG. And that lasts 2.5, 3 weeks for me. Nothing else gets the platelets up consistently above 30, except for Eltrombopag. But I still cannot get approval for it. With all the medications and treatments that I've been on, it's no doubt that it affected me with having depression and anxiety. And my relationship with my dear daughter, actually, when she was a teenager, was affected negatively. We have a good relationship, but that was a lot for me to handle all that stuff. And so I had to go on antidepressants, help me through. And last year I met another equally wonderful hematologist, Dr. Haley Merkley. She's helping me this year because my platelet count is consistently in the teens in the last half of this year. And I've needed to have IVIG twice. Life continues to be a battle with ITP for me. I've learned, of course, to live with it and find joy in the small things. During the pandemic, I've had to leave my job in a grocery store where I work at 1 day a week and have had to isolate most of this time because of being immunocompromised. My hope for the future for myself and for other patients with ITP is that maybe one day I will get approval to be able to take Eltrombopag or another one of the new drugs so that my platelets can be normal and my quality of life can be normal.
Thank you so much, Chrystal. That was amazing. It's
You're
great
welcome.
to hear that we have such wonderful hematologists in Vancouver. And I'm sure that Dr. Vickers was indeed smiling when your hemoglobin was 5 and you were sitting up in bed smiling. That's a good thing to see. Do we have anybody want to make any comments? I mean, it's really great to hear stories, but we have lots of hematologists who might have some comments, particularly about the medication.
Hi, Chrystal. It's Haley Merkley.
Hey.
Thank you so much for sharing your story. It is a really powerful story. And, you know, this just highlights an issue across Canada where access to, you know, really standard of care ITP treatments is sadly lacking. And so, you know, and Dr. Arnold might be able to comment on this further, but prior to the pandemic, there had been some movement, at least in Ontario, to advocate for more funding for novel TPO, well, they're not so novel anymore, for TPO agents. And unfortunately, I think we've had some setbacks in that regard, but hopefully we can catch up with the rest of the world in the near future.
Thank you.
Donnie, did you want to say anything on this?
No, I totally agree. I hate to say it, but it's a sad state of affairs in Canada when we think about access to medications. But I still think that your story is so important because it brings back the, you know, the hope and the importance in kind of trying and figuring out what's going to work for each individual patient. What's hard to teach about this disease is that there is no right answer. There has to be a series of trial and error, unfortunately, but you finally usually do land on something that works. So anyways, thanks for sharing that story. So important, really, for everybody.
Thank you. Yeah, you're welcome.
Okay, well, with that, thanks again, Chrystal.
You're
Really
welcome.
appreciate it.
Thank you.
Thank you. And we're going to just move on right into the next speaker, who's Dr. Donnie Arnold. And Donnie, you're going to share your screen. Do you have your talk, or do you want me to?
Yeah, I can do it.
Okay, good. Okay, so while you put that up there, I'm going to introduce you. So Dr. Donald, or Donnie Arnold, is a professor in the Department of Medicine at McMaster University and the director of the McMaster Center for Transfusion Research. Donnie obtained his medical degree at McGill, following this with fellowships in hematology and transfusion medicine. His research interests focus primarily on blood transfusion, blood safety, novel treatments and diagnostics, and as such, he's the lead investigator for several multi-center clinical trials in transfusion medicine, including most recently the Canadian clinical trial on convalescent plasma for hospitalized patients with COVID-19. Donnie has a broad and incredibly in-depth expertise in immunology, platelets, and hemostatic disorders, and has built an enviable world-class translational research program in blood disorders that investigates, among other things, the mechanisms underlying ITP and HIT, which you've just heard about. And in follow-up to our patient presentations, I can think of no better speaker. Donnie, all yours.
And thanks so much. And thanks to the organizers and to everyone really for giving the opportunity. I have to just share a very bizarre story that's happening right at this moment. So this whole world of COVID is so strange when we're doing Zoom meetings like this. I'm literally in my office. I'm on the 3rd floor, usually overlooking the campus at McMaster. Right now, right in front of my eyes, in my window, is a group of people on a very high lift, working very hard to restore some sort of broken cement block right on top of the outside of my building. So if someone comes crashing through the window and you see me kind of hide for cover, you'll know exactly what's happening right now. But very, very bizarre. Anyways, really a pleasure to be here. I feel like our patient story just gave me the best segue into this talk, which I've entitled Advances in Immune Thrombocytopenia, or ITP. I'm going to tell you a little bit about, I think, what maybe is some new information about ITP and how we manage it. Here's some disclosures. I've been fortunate to receive some grant support from pharmaceutical companies that make products for ITP, and acted as a consultant for some of them as well. In the next few minutes, 15 minutes or so, I want to try to cover some fundamental issues in this disease, but also give you what's, I guess, a snippet into the future about what I think is new and happening. Some of this is published, some of this isn't, and some of the work that we've been doing, but also highlighting other work that's important in the field. You've heard, and I couldn't describe it any better, the journey of ITP that patients often go through. It is often for many, many years trying to figure out, first of all, what's wrong, and secondly, how to treat it. But there's a lot of things that are unique to this disease that I think are worth mentioning. So for example, everyone's got low platelets. That's the defining feature of this disorder, but it manifests very differently in different people. So the picture to the left is a blood film of a patient who's got a platelet count of 9. And the only thing wrong with her is that her platelet count is low. She has no bleeding symptoms whatsoever. She feels perfectly well. And she's going about her business on a daily basis. The middle picture also is a young girl who has a platelet count of 9, but she's got a hemostatic impairment. So you see those very large blood blisters in her mouth, which usually signals that perhaps this is more serious than we know, and there's bleeding elsewhere, or bad bleeding is about to happen. And then finally, the picture on the right, also platelet count of 9, and this is what we fear the most, which is an intracerebral hemorrhage. So we have some challenges set in front of us, and not the least of which is to figure out who is going to end up with bleeding that we need to treat more aggressively, and who are the ones that we could leave alone so we don't end up over-treating them with corticosteroids and resulting in lots of side effects, some of which you've just heard about from the patient story. First order of business is let's talk about diagnosis. And what are some possible advances that we might be making in this area? Here's the state of affairs with ITP diagnosis right now. ITP is a clinical diagnosis characterized by the following criterion: a platelet count less than 100 with no underlying cause. Now, as far as diagnostic criteria go, that's probably just about as crummy as you get, because if you think about it, there are lots of things that will give you a platelet count less than 100 without a clear underlying cause. And so we call this a diagnosis of exclusion, but in practical medicine, that's actually very hard to enforce. And what it leads to is essentially the wrong diagnosis oftentimes. And in our hands, when we've looked at this over a period of about 10 years, we have a registry where we're kind of following patients with thrombocytopenia over time. We found that about 1 in 7 patients were either diagnosed with ITP when they turned out to have something else, or they were diagnosed with something else and they turned out to have ITP. And some of those are tricky, like hereditary thrombocytopenia syndromes, where some people have had their spleens removed because the diagnosis was felt to be ITP, but of course it didn't work because they didn't have ITP to begin with. And other examples of people going through surgery or other procedures essentially needlessly. So I think we have a lot of work to do to try to figure out, when a patient hits my office as a consulting hematologist, do I think this person really has ITP or do they have something else? I'll give you an example. This is a patient who I saw not too long ago. He's a 68-year-old male, referred to me for a platelet count of 36. He never required any therapy, but over time, his platelet count had been kind of dropping fairly gradually. In the meantime, over a period of a few years, he developed atrial fibrillation with a fairly high CHAD score and a previous TIA, so was put on a Pixaban. And now sent to me because, well, his platelet count is low and he's on a blood thinner. Is there something we should be doing differently? We did some investigations. He had a fatty liver when we looked at his ultrasound, but normal liver enzymes and normal spleen size. The rest of his blood count looked essentially normal. And he had no bleeding. Well, the first question I'm asking myself when I see someone like this is, what is the diagnosis? And unfortunately, we don't know. So we just don't have the answer. We don't have anything else really that's going to tell us if this is ITP or it's not. But that would be obviously very helpful, because this is the kind of person who probably needs treatment sooner than later, and we want to make sure we're doing the right thing and giving him the right therapy. Well, is there anything we could do to try to increase the diagnostic yield for someone like this? Are there characteristics of patients that might help us to predict that this person has ITP while this person does not? Well, one method for doing this is called a clinical prediction model. And if we applied that to ITP, we can ask this question: can we identify which patients with thrombocytopenia have ITP? Well, in order to do that, you kind of need a gold standard definition. And what we did in our group of, it was close to 900 patients with thrombocytopenia in our registry. We used response to intravenous immunoglobulin, IVIG, or response to dexamethasone or response to prednisone as the gold standard definition to say, if you achieve that, there's no doubt you had ITP. And so we used a model to say this group of ITP patients, 90 of them or so, fit some variables that would kind of suit the model for that group. That's called a training set, and then used it in a larger group of patients called a test set. And we looked for variables that were plausibly associated with the ITP diagnosis. This is new stuff. It's not been published yet, but hopefully soon will be. And we came up, so in doing that exercise, we came up with a new measure, which might actually be helpful in the future, but I'm not sure, it still has to be tested. Something called platelet volatility. Platelet volatility volatility is a borrowed term from financial markets. It's essentially a statistical measure of variation and dispersion over time. And it's calculated with mathematical equations that can help you actually give you a number. And basically what that means is platelet count fluctuates instead of staying relatively stable. And when we measured kind of platelet volatility as a score, it was actually quite helpful at differentiating people who had ITP versus people who did not, even though they may have had the same degree of thrombocytopenia. I'll show you a few examples. So the top is a patient with cirrhosis. Their platelet volatility index score is relatively low. And if you look at the graph, it's kind of flat. Same for someone with a big spleen, splenomegaly or hypersplenism, which could be a bit tricky clinically. Their PVI score also pretty low. And similar for someone with myelodysplastic syndrome. They all have low platelet counts, but they tend to stay fairly flat. Whereas patients with ITP, these are the next three, you see oftentimes these fluctuations over time. And it often is the case even if they don't get treatment. Their platelets might be at 30, then at 60, then at 20, then at 70, kind of up and down. There's a bit of a variation and as opposed to staying constant. So whether or not this is going to bear out as being something helpful to make the diagnosis, I still don't know, but I think it's an interesting measure that needs to be tested further. Okay, item number 2, which I think is critical, is emergency management of bleeding. This is what every clinician is afraid of, is that their patient with ITP and severe thrombocytopenia is going to have a major bleed. Well, I can tell you the bleeding ITP patient inevitably happens on a Friday evening when no one's around. There's chaos and pandemonium that ensues in the emergency room. It's a rare event, but it is life-threatening and people are very nervous about it. Not the least of whom is the patient, of course. And when you look to the evidence, there's a remarkable lack of data to help clinicians maneuver this very difficult situation. So what our group tried to do is put together a guideline panel. So we called it the Emergency Management Guideline Panel. And we got together and a very vast, broad group of specialties represented, including ER docs and hematologists, et cetera. And we just tried to attack this question of how do you treat the urgent ITP bleed? And what we realized right away is actually there's no definition. Well, first things first, we need to define what is a critical ITP bleed. So for example, no one's going to argue this is a patient with a platelet count of 10 and a bleed in their brain. Everyone would agree that is a critical ITP bleed. You would treat them very, very aggressively. What about this person though? This is a young male with a platelet count of 10 and has extensive blood blisters in his mouth. Now, is that a critical ITP bleed? Well, I'm not sure, but it might signal that a critical ITP bleed is on the way. And we might want to be aggressive, but maybe not as aggressive as the one with the intracerebral hemorrhage. And what about this patient? So platelet count of 10 also happens to be on a blood thinner, but their only manifestation right now is extensive petechiae on their skin. Is that a critical bleed? Well, again, maybe not, but certainly we'd be worried that it could develop into something bad. So we need to kind of figure out these gradations before we could move forward with treatment. Well, the first order of business happened with our ITP panel, and that was to come up with a definition for a critical ITP bleed. And here's where we landed. A patient with known or presumed ITP and a platelet count less than 20 who has either a bleed in a critical anatomical site, such as intracerebral hemorrhage, intraspinal, retroperitoneal, etc., or ongoing bleeding that's resulting in hemodynamic instability, like their blood pressure is falling or they've got respiratory compromise. Those would clearly be considered critical ITP bleeds, and you'd pull out all the stops. The hard part is going to become, well, how do you define people who are at risk of this happening, where you do need to be escalating therapy? Now, we don't have the answer as to what to do, but here's just a snapshot of emergency management, kind of a how I treat. In fact, this is how I treat. And essentially, it goes through several different modalities of therapy that might be useful for the person with ITP who presents with a critical bleed. The first item is platelet transfusions. And the reason why that's first is because they work the fastest, but they last the shortest. So they don't last very long at all. In fact, we know that if you give platelet transfusions to someone with ITP, they hardly last at all. But if you give enough of them, you might actually be able to get their platelet count up just a little bit for a small period of time while you're doing other things. And those other things might be IVIG, corticosteroids, and maybe even something like a TPO receptor agonist like Eltrombopag or Nplate, as we heard in our patient journey. More to come on this. We haven't quite landed on things, but certainly the questions are becoming a little bit more clear. Okay, third advance in ITP that I think is worth mentioning. And again, the patient journey that we just heard about touched on this on several instances. One, when we heard about Chrystal going through a splenectomy and then a gallbladder surgery, it's perioperative management. How do we help people with ITP get through surgery when their platelet count is very low? Well, I'm going to say this is mostly a man-made, woman-made problem. This is not really based on medical biology. This is more based on comfort levels of surgeons, comfort levels of anesthesiologists. And that's fair enough, but it just means that there's very little guidance to help us get to our thresholds. For whatever, however we want to slice it, the best kind of general rule is that for minor surgery, we want a platelet count at least 50. For major surgery, a platelet count over 100. But how do you manage to get platelets to those levels in patients with ITP who are undergoing surgery? Well, there's a few options. You could use IVIG, which is rapid and transient, but it's fairly expensive and it's a blood product. So we could, if we can avoid using it, probably a good idea. You could use corticosteroids, but their response is a bit less predictable. You've heard about all kinds of toxicities from corticosteroids already, especially in the setting of surgery. Sometimes that's worth avoiding, but very inexpensive. And finally, thrombopoietin receptor agonists, something like Eltrombopag, which is an oral form. There's some reasonable observational data that say that they work, but concerns about potential thrombosis and maybe even bleeding in observational studies. Well, our group, and with help from centers from across Canada, led a pan-Canadian randomized controlled trial in perioperative management of ITP, comparing IVIG as the standard treatment versus Eltrombopag, which is an oral medication. And fast forward to the end, here's what we found. The study was designed as a non-inferiority study. In other words, our hypothesis was that Eltrombopag was no worse than IVIG at getting people through surgery. And in fact, that's what we showed. Eltrombopag was non-inferior to IVIG for all surgeries. It was certainly most pronounced for the major surgery categories and a little bit less obvious for the minor ones. And in fact, when we looked at our secondary outcome of superiority in our intention to treat analysis, it looked like Eltrombopag may even have been superior to IVIG at getting people through surgery. The downside, perhaps, is that there were 2 episodes of thrombosis in the trial. One was a pulmonary embolism in a patient who had been taking Eltrombopag and had a very minor surgical procedure. So there was not much doubt that it was likely related to the Eltrombopag. The second thrombotic event happened in a patient who was in the IVIG group, but this was 30 days after major surgery where they did not get medical thromboprophylaxis, they only got mechanical thromboprophylaxis. So it could have easily been related to the surgery. So in conclusion, I think ITP is an old disease, but we're making some advances in some fundamental aspects, including diagnosis, critical bleed management, and perioperative care. Thank you so much for your attention today.
That was great, Donnie. Can you de-share? Thanks. And I trust that the cement didn't fall on you.
They're still working out here, though.
Cool. All right. Quick question while others gather questions, but the Eltrombopag, what's the mechanism of the thrombosis?
So that's a good question. And it probably not related to a high platelet count. In other words, sometimes when we give these drugs, we see platelet counts go fairly high. We've seen thrombosis occur even when platelet count is not overly high. So it may be related to a platelet priming or some sort of activation, or maybe these very young platelets that are coming out of the bone marrow or kind of more primed for thrombotic needus, perhaps. We don't really know, and I'm going to say it's subtle. So it doesn't happen frequently that people on these drugs end up with thrombotic complications, but it's certainly described and it happens once in a while. So we're nervous about it.
Okay. So Gary Gilbert, and then I can see Wolfgang online as well. Okay, yeah. So Gary, hi.
Hi, we have several people at our institution who argue that one should look at the mean platelet volume to help distinguish ITP from thrombocytopenia of other causes. I'm just wondering how that parsed out in your study.
Yeah, good question. So I can't really say because we haven't quite finished this prediction model yet, but MPV would be a very important one to look at. I feel like in my experience looking at patients with thrombocytopenia, I have been less impressed, I'll say underwhelmed, with MPV as being a helpful distinguisher between ITP and non-immune thrombocytopenia. But in some cases, it seems to be true, where you might even see the MPV remarkably high. And that's when you say, oh, actually, maybe there is something going on here. But I don't know the answer to your question with data. My sense is that people are polarized about it, and I'm not totally convinced that it's helpful.
Okay. Yeah, my own impression was that it's specific but not sensitive, but we'll see what your data shows.
I think that's a good assessment.
Okay.
Yeah, so I'm curious about the low platelet count and who bleeds and who doesn't bleed, and I'm sure there's no answer to that, but so 2 questions to it. So A, do people also look at platelet function? And I seem to remember that there's hypofunction in platelets in at least some ITP patients, and does that correlate at all to who bleeds and who doesn't? And then also, if somebody is young and has a low platelet count and doesn't bleed, does that continue through life? Or do people become bleeders later on? Or is somebody who is not a bleeder initially never, or rarely becomes a bleeder later on, and who bleeds from the beginning bleeds later on too?
So great questions altogether. There have been a few studies looking at platelet function in ITP. And one out of Boston not that long ago, probably 4 or 5 years, it looked like if you can do platelet aggregation testing in some of those patients, you may be able to find subtle differences that differentiate bleeders versus non-bleeders. And it might not be the traditional platelet aggregation because those are really hard to do when patients are thrombocytopenic. So I think there is probably a difference between those two groups of bleeders and non-bleeders with respect to platelet function. The other question is more, you know, if you're a bleeder, does that kind of stay with you through life, or does it evolve over time? I don't have a lot of data to back this up, but my sense is that some people bleed and some people don't. And the ones that don't bleed tend not to bleed as you follow them through. And the ones that do, I think there's periods of their disease that are more prone to bleeding. So for example, when they go from very high to very low, like they crash, that's often when you might see them manifest as bleeding. And you kind of, you know, some patients just don't tolerate a platelet count, let's say less than 10, whereas others do. So there's got to be more to it than just the platelet count number, but I'm not sure I know what that is.
Thank you.
Ed, you're muted. I can't hear what you're saying.
I can't understand that. What's the problem? Here, okay, fine. What is, there's a couple of chat questions.
Oh.
What is your opinion about the new concept related to the use of oseltamivir, phosphate and ITP with platelet desylation and the combination with other medications?
Yeah, so this is a really interesting area of study. And that is that oseltamivir is a flu medication, and its mechanism of action is to prevent desylation. I think I'm right about that. And desylation is one of the mechanisms by which if platelets start losing their sugars, then the surface becomes recognized by non-immune receptors in the liver, which bind up the platelets and remove them. So that may be another mechanism of platelet destruction. And if you prevent the desylation, you may allow the platelet count to rise. I think the clinical experience has been mixed. There's been some case reports where oseltamivir has remarkably made platelet counts go up in patients with ITP. But as far as I know, in reasonable studies of reasonable sizes, I should say, it's been more of a wash. I don't think there's been a great signal to say that this is a very active compound for ITP treatment.
I got a couple of questions. I'll get to you. Hey, you, I know you're around. Okay, so Peter Grin first. So what is the minimum amount of time you need to follow a patient's platelet counts to calculate a PVI with useful predictive value?
Yeah, excellent. So we're kind of learning as we go here. This is brand new stuff. I would say that from the work that we've done looking at this almost mathematically, you need at least 3 values to say that there's a fluctuation. And one of the limitations I would think of this equation is that, you know, if you had 3 values within 3 weeks or 3 values within 3 months, you're still going to end up with a similar result. So it's kind of time independent. Maybe that's a limitation. Whereas that's probably the low end. And if you have at least, I think it's 8, once you get past 8 platelet counts, you probably don't add much value. So at least 3 and probably at most 8 is what you need to calculate it. Still early days to say if it's really going to be helpful making the diagnosis, but who knows? It's better than we've got now, what we've got now, which is essentially nothing.
Hey, you, quick one.
Great talk. Arnold, Dr. Arnold, so that was great talk.
Thanks.
So regarding the bleeding problems, so some of these patients may have antibody directly block the fibrinogen bonding or von Willebrand factor bonding. We observed from some of these cases. And particularly one of the patients that died in Stony Brook, Toronto, so that patient has a high, the antibody block GPMB alpha bonding to von Willebrand factor. That patient also induced very high platelet desylation. So then that is uncontrollable by our doctors here. So therefore patient passed away. I would think that some of this autoantibody may indeed block that platelet function directly. And regarding the platelet desylation, I would think they do have some of the clinical information from Spain, from France, as well as from China, seems to me that that's indeed linked, that resistant. If the patient has a higher platelet desylation, seems to be more resistant to the first-line therapy.
Yeah, great points, Hey-Yu. I think you're absolutely right. There are antibodies in ITP, some of which may interfere with platelet function. That is the exception to the rule, but when it happens, they become very severe. And I agree with you, some of those very challenging bleeding patients have antibodies that have almost dual or triple function, which is interesting.
I think we're going to have to wrap it. There's lots more questions, Donnie. You can find him at McMaster, I'm sure, by email. You can send him chat questions as well. So, but thanks so much, Donnie. That was fantastic. Followed up beautifully with our patients. So thanks for coming.
My pleasure. Thank you.
Stay safe there, huh?
Yes, thank you.
All right, good. Dr. Ortel, Tom, are you around? He's in the crowd. There
I'm
he
here.
is. Hi, Tom. How are you?
Very good. How are you?
Good. So you're going to share your screen because I don't have your slides in any case. So if you can set up your slide sharing and I'll introduce you.
Okay.
All right. So Dr. Thomas Ortel is our second keynote speaker. Tom is a professor of medicine and of pathology and the chief of the division of hematology at Duke University in Durham, North Carolina. As Tom tells his story, he suffered as a child with severe allergies and thus spent many hours and days in doctor's offices surrounded by medicine. This had a huge impact, piquing his curiosity in medicine and the mechanisms of disease, while at the same time providing a deep appreciation of the patient perspective. This is extended through his life and career. At Indiana University, he completed his PhD and then his medical degree, subsequently moving to Duke University for his medical residency and fellowships in hematology oncology. There, he rapidly moved up the ranks, establishing himself in the lab and the clinic as a leading investigator of the molecular mechanisms underlying dysfunctional hemostasis. Now, I neglected to get a CV from Tom prior to the meeting, but rather went online to gather some background information. Needless to say, he's received multiple awards. He's on the editorial board of Blood and an active member of ASH. He's a dedicated educator and has helped in the formulation of numerous key guidelines for the management of patients with VTE, ITP, HIT, antiphospholipid syndrome, and most recently with COVID-19 associated coagulopathy. But really what caught my eye were the comments of his patients. So quote, "I received exceptional care by Dr. Ortel. He helped me figure out what was going on and provided key information to help me understand it so I can make appropriate decisions at home and with my other specialists. He's been a key partner to getting my life back, from being scared of dying to running a mile in the park after this appointment. Knowledge is power, and I'm grateful he shared his knowledge with me." So throughout his career, Dr. Ortel has truly married the lab and the clinic, and it's a pleasure to introduce him as our Earl Davie keynote speaker. So Tom?
Thank you. Thank you very much, Ed, for that kind introduction. And I'd also like to thank the organizers for inviting me to speak here today. After some thought about different topics, I thought this actually would be a very appropriate topic to speak about now, where we are. And actually, what I want to do with this presentation is present a plea for people who would be potentially interested in participating in a clinical trial if we can't get your site open. So these are my disclosures, none of which are relevant to today's presentation. And just some background, although everybody knows this. WHO was first notified on the 31st of December last year about an outbreak of pneumonia in Wuhan. And within less than a month, the first papers started appearing about the clinical features of patients infected with this virus. And if you go onto PubMed now, you'll find that there's something like a staggering 75,000 or so papers that are listed on PubMed. So this has exploded the amount of information. Unfortunately, there's a lot of information that doesn't necessarily help us with how we would manage patients. So I want to focus again on this issue of antithrombotic therapy in patients with COVID-19. We'll start with a story of the thrombotic risk in hospitalized patients and how that evolved, and what that has led to as far as our understanding currently of what goes on with these patients. So the first piece in this puzzle was the early recognition that the D-dimer was actually a valuable test, laboratory clinical test, to help with predicting outcomes in patients. And it was associated with an increased risk of being in an ICU if you had elevated levels compared to if you weren't in an ICU. It was also associated with an increased risk of death the higher your D-dimer level was. And you could see in a graph from the same paper that the individuals who did not survive their hospitalization with COVID-19 had a progressively increasing D-dimer level. And then more recently, studies that have shown that elevated D-dimer levels are actually associated with a lot of aspects of adverse events with COVID-19, including the development of critical illness, the development of thrombotic complications, which is our focus today, the development of acute kidney injury, but also a decreased likelihood that you will be discharged at least alive from the hospital if your D-dimer is elevated. So this was early in the course of the disease and recognition. The whole issue of thromboembolic complications really began coming out once the pandemic hit into Europe, and several European investigators were the first to report on this. This was the paper from Clock, which appeared on, available online on the 10th of April. So about 3 months, a little over 3 months into when this was first reported to the WHO, they had 184 patients with proven COVID-19 pneumonia admitted to their ICU. About a little over a third of them had some type of coagulopathy, not just an elevated D-dimer, but something else, either prolonged PT, PTT. All of these patients were receiving at least standard dose thromboprophylaxis, although the regimens differed between the hospitals, and the doses were changed over time in response to what they began to note. And this was their cumulative incidence of venous and arterial thrombotic events. And this was the main figure in this whole paper as far as what was what they wanted to convey, which was patients in the ICU by day 15, almost 30% of them had sustained some type of thromboembolic event. Most of these were venous thromboembolic events, most DVT-PE. They were not routinely screening everybody in this particular study, but this included, for example, line-related clots. It included a couple people with stroke, et cetera. But this was the first paper that suggested that this patient population has an increased risk of events. The second paper that came out, again, within a few weeks after the Clock paper, was from Saskia Middeldorp and colleagues, and they reported on 198 hospitalized patients hospitalized at their medical center. 75, so not quite half, were admitted to an ICU. All of these people were getting some type of thromboprophylaxis. Nadroperin was given to everybody, and a double dose was given to people with a body weight greater than 100 kilos. But then, as you can see again, about halfway into this trial, they started administering a double dose of nadroperin to patients on the wards, essentially going to this higher or escalated thromboprophylactic strategy. And what led to them to do that was this observation: the number of people who were having events. So on the panel A here, this is the total venous thromboembolic events in the ICU in red, and in the non-ICU in black. In the ICU, it's just shy of 60% of the individuals had sustained some type of thromboembolic event. Panel B shows the same data, but with only symptomatic VTE shown. So here, a lot of what they were picking up was they were doing CT scans on these patients when they were getting admitted or when they were going to the ICU to evaluate increasing hypoxia, and we're finding these even if the individuals did not have symptoms suggestive of PE at the time. But even if you only look at the symptomatic people, almost not quite 40% of the individuals in the ICU were diagnosed with some type of venous thromboembolic event. Now, expanding further, this is one of the first studies that came out of NYU, New York City being particularly hard hit by the virus early in its course in the US. This study reported on a little over 3,000 consecutive hospitalized COVID patients at NYU. Most of these patients were getting some type of low-dose strategy. And the key data is kind of over here on the right-hand side. 84% of these individuals did not sustain any thrombotic event. 16% sustained some type of thrombotic event. You can see here, 3% with PE, little less than 4% with DVT. Significantly, 8.9% with myocardial ischemia and myocardial infarct. So expanding the problem into also arterial circulation as being a source of events in these patients. Now, one of the key questions was that it's been recognized over the years that patients with viral pneumonias do have an increased risk for thrombosis. The issue is it more frequent in patients with COVID-19 than with other viral pneumonias? And this was a study that was reported again from the group at NYU, where they looked at thrombosis in individuals hospitalized in 2019 or in earlier years with non-COVID pneumonia and compared it to COVID pneumonia. So a nationwide survey, 2002 to 2014, of patients with non-COVID pneumonia, they had 954,000 individuals compared to patients with COVID pneumonia, the 3,334. You can see on here the events, any thrombotic event occurring in these individuals was almost threefold increased in the patients with COVID-19 versus other non-COVID-19 viral pneumonias or respiratory illnesses. All of the variables were increased: myocardial infarction, DVT, PE, ischemic stroke, and other systemic embolism. And what became obvious as the autopsy data began to come out was that the thrombotic events appeared to be different, in that not only did you have macrovascular thrombosis, thromboembolic events, but you also had microvascular thrombotic events that were noted, including fibrin thrombi that were forming in capillaries within the alveoli. So you were having macrovascular and microvascular thrombosis. Some of the microvascular thrombosis raising this question of what's now being referred to as immunothrombosis, or possibly endogenous thrombosis forming within the lungs. You can find thrombotic events in other tissues. So there's an increase in thrombotic events. What about anticoagulants now? What about the antithrombotics? Well, this was a really, the first study that actually suggested that anticoagulant therapy is doing something. This was just a study that looked at patients in Chinese and one of the hospitals in Wuhan, and just kind of split them out based on their D-dimer level and whether or not they were getting heparin. There was no pre-selection in this. They just looked at who was getting heparin and what was the D-dimer. And what you can see is that in the individuals who had the highest D-dimer levels reported, if they were getting an anticoagulant, they actually had a decrease in their mortality, as you can see on this side of the graph. The individuals who were lower D-dimer levels really didn't seem to benefit. This led to other people looking at anticoagulant therapies, and this paper came out after, again, the pandemic had gone through New York. This was a paper that was just looking at hospitalized COVID-19 patients. 786, or about a quarter of whom, received systemic treatment dose anticoagulant therapy, and they're comparing it to non-treatment dose anticoagulant therapy. And this was their data as far as survival probability. All patients, those individuals on treatment dose anticoagulant therapy, are in blue. Those patients who are on non-treatment dose anticoagulant therapy are in red. That says no in-hospital anticoagulation. That means no in-hospital therapeutic dose anticoagulation. These people may have gotten prophylactic dose, et cetera, but there was clearly a difference in survival. And if you went to those individuals who required mechanical ventilation, that difference became even more pronounced. And this was one of the first papers that again suggested that maybe these patients need something more than just prophylactic dose anticoagulants. Now, the problem with this, however, is that other papers have come out in the same time frame that have argued that therapeutic dose anticoagulants may not be the best thing. And this was a paper from George Washington University Hospital that looked at 431 patients, 250 treated with prophylactic anticoagulants, 152 treated with therapeutic anticoagulants. Again, retrospective analyses, no prospective division on who's getting therapeutics or prophylactics, just how they were treated. These folks who on the therapeutic anticoagulant arm were generally older, more likely to be in an ICU, and had prior cardiovascular disease. The unadjusted hospital mortality was 35%, 34.8% for those people who were getting therapeutic anticoagulants, compared to 15.2% for patients on prophylactic anticoagulants. And one of the points that they wanted to make in this paper was no matter how you sliced it and diced it, and they looked at it a number of different ways, and this is the all ICU patients, and survival probability, depending on the time in days that you were getting your treatment, whether you were getting therapeutic or prophylactic, there was no improvement in outcomes in their study. So in the earlier study, you see a difference. In this study, you don't see any difference. Again, this is all retrospective data. Now, a number of people began arguing early on that maybe you don't need therapeutic dose, maybe you need something in between. And this was the study that just came out that was looking at single center before-after design study. Again, no randomization in any of these studies that have been presented so far. What they were looking at was a thromboprophylactic strategy that looked at augmented low molecular weight heparin dosing, giving more than prophylactic, but not quite therapeutic. And what they were looking for was 1 month mortality data. And this made this paper look really great because before you had mortality rates in the 20 to 40% range by 1 month out, whereas the mortality rates were much lower in the people getting therapeutic dose, or not therapeutic dose, subtherapeutic dose low molecular weight heparin. However, again, you can find a study that counters this completely. This was one that just came out in on the paper version of JTH, labeled the hazard of, quote, or parentheses, subtherapeutic anticoagulation. And here they had 324 patients with COVID-19, 240 were on prophylactic dose, 84 got some kind of higher dose anticoagulant. It was more than prophylactic, but it wasn't therapeutic. And what they showed was on this, the primary endpoint was major bleeding with clinically relevant non-major bleeding. And what you can see is what you managed to do was you increased the frequency of bleeding events, both major bleeding and clinically relevant non-major bleeding. And you really didn't have any impact on the frequency of venous thromboembolic events or death by this study. So again, every study favoring some kind of more aggressive anticoagulant ended up being countered by one that showed that really it didn't work and it may cause more harm. So what are kind of guidance recommendations that are out there? Thinking about this is the quality of the data that all of this is being recommended on. This is the most recent guidance, and you can pick whichever one you want to pick. There's multiple ones. I just picked this one because it's the most recent one that's come out. VTE thromboprophylaxis in the hospitalized patient with COVID-19. In the non-ICU patient, universal strategy of routine thromboprophylaxis with standard dose unfractionated heparin or low molecular weight heparin should be used after careful assessment of the bleeding risk. Low molecular weight heparin being a preferred agent. But then they go on to say that a third of the respondents actually recommended doing one of these intermediate dose low molecular weight heparin regimens. Furthermore, when you get into the ICU patient population, routine thromboprophylaxis with prophylactic dose unfractionated heparin or low molecular weight heparin should be used after careful assessment of bleeding risk. Again, up to half of the individuals felt that an intermediate dose could also be considered in these. So you've got a lot of heterogeneity in the responses in how aggressive we should be treating these folks. So this is in the hospital setting. What about when they're discharged from the hospital? Now there's good data that's from older studies that have looked at it and shown that actually in patients who get hospitalized and then are discharged from the hospital, that increased risk of thrombosis persists. And this was a market scan analysis that showed that almost half of all thrombotic events associated with a hospitalization occurred after discharge, suggesting that people needed something more for preventing thrombosis after they get discharged. Now, multiple clinical trials have shown some modest benefit, but it's usually offset by bleeding. So we don't do it for most patients. But what about COVID? Well, there's only been a couple of studies that have looked at this, and one was published in Blood a couple months ago now. It was an ongoing quality improvement program that used a root cause analysis of all hospital-associated VTE. They had old data from 2019. They pulled all of that out and had, over a 42-day course, a rate of 3.1 per 1,000 discharges. When they looked at their COVID data, again, 42 days post-discharge rate, 4.8 per 1,000 discharges, which gave an odds ratio of about 1.6. So maybe slightly increased, but not statistically significant. Now, another paper that appeared in the same issue in Blood was a retrospective observational study of 163 patients with median time from discharge to last recorded follow-up of 30 days. Characteristics of the cohort was that a quarter of them were in the ICU, but the length of stay was relatively short for a significant number. So the median was 6 days with an interquartile range of 3 to 12 days. So a number of these patients were getting out fairly early, so a relatively less sick patient population. The primary outcome was thrombosis or hemorrhage at day 30 after discharge in patients not receiving post-discharge thromboprophylaxis. The cumulative incidence of thromboembolic events, venous and arterial, was 2.5%. Cumulative incidence of major bleeding was 0.7%. Clinically relevant non-major bleeding was 2.9%. And you can see here on the left in blue is the cumulative incidence of thrombosis. And on the right is the cumulative incidence of hemorrhage. And these rates are not that dissimilar to rates of patients for regular hospital admissions, non-COVID related. Now, admittedly, neither of these trials focused on the higher risk patient population, those who've been in the ICU for a number of days, et cetera. Now, what's the guidance for VTE prophylaxis here? Either low molecular weight heparin or a DOAC can be used if you wanted to use something. And then extended post-discharge thromboprophylaxis should be considered for all hospitalized patients with COVID-19 that meet high VTE risk criteria. And duration may be 14 days and up to 30 days. So it's suggesting to use this in the absence of data that it's necessarily really increased. Now, what about in the patient who's never admitted to the hospital? Do they have an increased risk of events? Well, anecdotes suggest that thrombotic events do occur. There's multiple case reports like this one. There's also in autopsy series, 2 of 12 reported cases died outside the hospital setting and had pulmonary thrombi at autopsy. And then in a study that we just reported, 5 of the 7 radiographically confirmed PE that we identified in the first 192 patients were actually sustained in the outpatient setting. 3 of them before any admission to the hospital, 2 of them after a discharge. So we're seeing outpatient events. But what kind of other studies do we have? Very few. This was a study that looked at thromboembolic events in patients with COVID-19, a little over 1,000 patients. And what's key is major ATE or VTE was likely to occur in the ICU population, relatively less frequent in the non-ICU population, and they did not see any events in the outpatient setting. So what guidance do we have here? Well, you can see it right there. There is no guidance. There's nothing right now for what we should do with these people. So what I want to do in the last couple minutes is just introduce you to 3 trials that are part of the active 4 trials that are looking at these 3 settings to introduce antithrombotic therapy and try to study it in inpatients, outpatients, and in the post-hospital course of patients. ACTIVE stands for the Accelerating COVID-19 Therapeutic Interventions and Vaccines. This is the trials funded by the NIH and Operation Warp Speed. First trial is inpatient study. This is chaired by Judy Hockman out of NYU, and the PI on the study is Jeff Berger. They are open, enrolling, currently have a little over 100 patients enrolled, and they're comparing a therapeutic dose anticoagulant to prophylactic dose anticoagulant as the control. It's a pragmatic design, so you can have different anticoagulants in either arm. There's a number of different ways that they're breaking down the data to analyze it. Inclusion, exclusion criteria are shown here. Primary outcome is going to be 21-day organ support, 3 days. So not getting intubated, not requiring pressors, etc. Safety endpoints, major bleeding defined by the ISTH. Study design features are co-enrollment in other COVID-19 related trials is permitted unless you have an anticoagulant that you're studying. They're looking at adding another arm in addition to this idea of therapeutic versus prophylactic anticoagulant. And one of the things that's being considered is antiplatelet therapies. What about outpatient setting? This is a trial that's been designed by Paul Ridker, and his PI working with him is Gene Connors at the Brigham. And this is a trial that's looking at patients who are not admitted, diagnosed in an emergency room or some other urgent care setting, and they are getting randomized double-blind placebo-controlled trial to placebo, aspirin, apixaban 2.5 twice a day, or apixaban 5 twice a day. The key inclusion and exclusion criteria are shown here to the right, and they are collecting data for D-dimer and CRP levels that are going to help with analysis at the end to see if they can identify a high-risk subset. Patients are getting treated for 45 days, and there's an additional 30 days for safety follow-up. Paul's trial is also open. It's only open at a few centers now, but they are interested in getting more centers to enroll. The key here is that the site really only enrolls the patient, and then everything goes into a telemedicine phase, either by texting with the patient or calling the patient to get follow-up outcomes. The last one to mention is the post-hospital study. This is a trial that I'm the study chair on, and Tracy Wang from the Clinical Research Institute is our PI on this study. This is looking at people who have been in the hospital, they're getting discharged. It's a double-blind, placebo-controlled, randomized trial that's comparing apixaban for 30 days to matching placebo for 30 days. The outcomes on both the outpatient trial and on the post-hospital trial is a composite outcome of VTE, ATE, major bleeding, and all-cause death. Paul's trial also has as one of the outcome events hospitalization. The Active-4C post-hospital study, just to mention a few other things about it, patients are going to be stratified by D-dimer level and maximal WHO severity scale during the hospital course. There is a biorepository that's collecting samples, and we're actually going to be able to run some analyses on these folks to identify high-risk markers and or mechanisms of thrombosis in patients. We are collecting enough data to calculate an improved VTE score and see if that will help us identify who would benefit from thromboprophylaxis. This is adaptive trial design, as all of these trials are, to enable us to do further studies as needed. What are some unique barriers to doing COVID-19 studies? Well, there's rapidly changing clinical field with new diagnostics and therapeutics coming out all the time. There's changing locations of the pandemic, so you may have to move your sites as far as who's enrolling and when. There's difficulties recruiting, enrolling, and following patients with a highly infectious disease in a clinical study. So both of the outpatient trials actually are doing remote follow-up. Need for novel strategies to enroll patients. Active-4B, which is the outpatient trial, is really exploring some novel ways to try to get patients into their study. There's also, unfortunately, a lack of clinical equipoise concerning treatment arms. Some people think that a high dimer level mandates doing something different, which we have, again, as you've seen, no data to support that. And it's also important that we make sure that all of these trials enroll the high-risk patient subsets, the individuals who are disproportionately affected by COVID-19. So we want to make sure that we get these individuals in these trials. So in conclusion, thrombotic events appear to occur more frequently in patients with COVID-19, particularly for those who require hospitalization, particularly ICU setting. Optimal thromboprophylactic regimen for hospitalized patients with COVID-19, however, still needs to be defined, and a randomized prospective clinical trial is what we need to do that. The role of thromboprophylactic therapy in non-hospitalized patients and in patients recently discharged from the hospital needs to be determined, and the subsets of folks who may benefit and who may not benefit need to be identified. And if anything, I want to please ask people, enroll your patients with COVID-19 in the clinical trials. I've got the information on how to contact any of the sites, any of the groups about any of the trials if you're interested, or if you want to, feel free to reach out to me directly and I will put you in contact with the organizers for the different trials so that we can talk about getting the site open. The post-hospital discharge trial, I hope to have open within a couple of weeks. We're just a little bit behind the other two, which are both open. With that, let me thank everybody for your attention, and I'm happy to take any questions.
Thanks, Tom. That was perfect. That was wonderful. Could you unshare your screen, please? I think everybody can grab that. That was terrific. I'm sure there's going to be lots of questions. I'm just going to look before. Oof, there's loads. Okay, so if people want to jump in and speak, I'm just going to ask Mary. I know that you gave a talk, so on this particular topic, do you want to jump in? Oh, there you are. Hi.
Hi, I'm back. I've moved. I'm home now. So yeah, I mean, I spoke about this topic at AHA today, and I was asked to talk about mechanisms. So it was kind of a different sort of talk, and I talked a little bit about trials and a little bit about observational evidence. So Tom, I would love to take your slides and my slides and put them together into like a full-length talk. I think it would be super cool. But Tom, you know, deserves so much credit for leading that post-discharge trial group. I'm fortunate to be involved with the inpatient trial as part of the protocol development committee. And it's been such an amazing experience. I mean, the main thing I want to share with people is how amazing this experience has been as a scientist to be involved in this sort of research, to be really thinking about the hematologic mechanisms in this disease, which aren't getting enough attention. And, you know, I really believe that antithrombotic interventions are going to make a difference for patients and, you know, hasten their recovery from this disease if we can get these trials done. So it's really, really hard to do this kind of research in the pandemic setting. And any of you who might be interested, if your hospitals aren't engaged in these trials and you want to be, please come forward. And, you know, I think hematologists are champions for this. And I feel like it's a hematologist disease as much as it is a virologist. That's my own personal view. So thank you, Tom, for the really clear story that you gave. And I'm happy to help any of you who are interested in getting involved.
Great, thanks, Mary. I'm going to just jump to, there's some chat questions before we jump to the others. So from Jess Halpern, are you aware of similar clinical trials in pediatric patients hospitalized with COVID-19?
So that's a good question. All of us, the current 3 trials are not enrolling pediatric patients, and it was because at the time as the disease was evolving, we've seen that the pediatric presentation was a little bit different than it is in the adult setting. So I suspect that there are small studies that are ongoing. We're open to exploring what might be a valuable way to do this as a subsequent trial or a spin-off trial, but none of the 3 that I presented are enrolling pediatric patients.
And from Haley Merkley, another of our hematologists who you heard from a little bit before, is asking about examining for higher risk subgroups of patients such as pregnancy, sickle cell trait, or disease.
So we tried to make these trials as comprehensive as we could be for adults. The post-hospital trial does not exclude anybody. For example, we're also including cancer patients in the trial. Sickle cell trait or disease patients could be in the trial. Pregnancy cannot be in either the outpatient or the post-hospital course, post-hospital discharge because of the apixaban and not using that in pregnant women. So we aren't enrolling pregnant patients in these trials at this point. But other high-risk subsets we are open to getting, yes.
Okay, I'm going to go to Wolfgang, Gary, and then Chrystal.
Yeah, great talk. I was just wondering if there are trials that match up anticoagulants with, let's say, anti-inflammatory IL-6 inhibitors to see if you can use a lower dose anticoagulant if you add a different approach on top of it.
So that's a great question, and that's the kind of thing that actually what NIH and what the Connects group, which is kind of the super group that's over all of these trials, is very interested in exploring. So active 4 is the anticoagulant part. The other actives are looking at actually other strategies for treating COVID. But the interest is trying to, at some point, potentially look into whether or not combining some of these or leading to other opportunities to add therapies or combine therapies would make a difference. That's exactly what people are beginning to start designing. There is one trial, for example, there is a trial out there that's looking at patients and enrolling them, kind of doing a double randomization in which you start out going to one anticoagulant or another, one dose or another, and then within that subset, atorvastatin is kind of being randomized in there as a statin approach on top of this. So I think that you're going to see more of these coming out. Right now, while we've got the pandemic going on and we've got plenty of cases in the US, we would just like to see the numbers enrolled to answer these basic, simple first questions and then explore these kind of subset questions as you're posing. But I think in the long term, that's the direction we go.
You may not have the cases anymore if there's a vaccine, though. So.
You got a little time.
Well, with the number of people in the US who aren't going to take the vaccine.
I'd vote for complement inhibitors in your selection criteria there. That's a personal bias. Gary Gilbert.
Oh. Hey, Tom, great talk.
Thanks, Gary.
I did the e-consults for the VA during, from March through June. And so I did every person who wanted an e-consult with the VA from the Canadian border to Connecticut, they were talking to me. And as a result, I saw, and that included in rehab. And I saw something, I think 3 times that I just like to have your thoughts on. So I think there were 3 different patients who were transitioned from the acute care hospital to convalescence at one of our convalescent facilities. And on discharge, one had a normal D-dimer, another one had it within 2x of normal. And neither had ever had high D-dimers in the hospital. And in rehab, as they were getting better, as they were walking and doing all their strength gaining activities, their D-dimers went sky high, like off the outside of the range, above 3,000 outside of the range. And so, of course, their docs are getting an e-consult, what shall I do? I said, well, let's give them prophylactic heparin, because prophylactic Lovenox. So, but it brought to mind that it appears that this endothelial phase, this vascular phase, whatever it is, can be decoupled temporally from the acute respiratory phase. For at least these 3 patients that I saw electronically, I looked at their data. And I'm just curious what your thoughts are about that and how that translates into, I don't know, practice or clinical trials.
It's an interesting question. Now, at this point in time, my first question to them would be, why did you draw it in the first place?
Fair enough.
If the person was getting well, I think I'd go there. But that's actually why we're hoping that we can get the biorepository piece up. If we can get, and our biorepository for the post-discharge is going to be a sample drawn at the time of discharge and then a sample drawn after they complete the anticoagulant. So about day 30 to 45. And we're interested in looking at some of these questions. So for example, the people who have an event, do they have higher dimer at discharge or do they have higher dimer later? So we would actually be able to look at some of these things in a series of samples collected as part of a clinical trial. And I think until we get data like that, it's hard to know what to do with laboratory results in the absence of clinical manifestations of something. So I'm really hoping that these people were complaining about leg hurt or something and somebody ordered a dimer. Otherwise, I find that the dimers that are positive in people who are in situations like that, I have no clue what to do.
Yeah, I had I had one that I did yet another e-consult a few days ago now 6 weeks since discharge, D-dimer is finally down to about 2x the upper limit of normal. And I said, stop the Lovenox for God's sake. Who knows what his baseline D-dimer was before he was admitted 6 months ago.
Well, yeah, Gary, I mean, a lot of people live at that level.
Yeah. But his had gone outside of the measurable range and then slowly come back, and again, because in COVID-19, nobody knows what to measure and D-dimer's abnormal. So there were a whole bunch of them to chart, and I could chart out the course.
I'm going to jump in. Okay, Ed, did you want to ask a quick question?
Yeah, I just wondering, SARS-CoV-2 is difficult to measure at the best of times, but I'm just wondering if any of these clinical trials are trying to measure it along the course of antithrombotic treatment.
No, not specifically, other than all three trials. For example, the inpatient trial does have biorepository samples being collected, I think, weekly during the treatment phase. And the outpatient trial does have a blood sample collected at baseline. But the outpatient trials, it gets difficult because we're trying to obviously minimize contact with individuals.
Very true.
So
it would just be inpatient. Yeah, just based on the idea that some anticoagulants will be affecting the ability for some of our favorite enzymes to trigger protease activated receptors, whereas others will not. Viruses like protease activated receptors to be triggered. Right. And that's all I wanted to discuss with you, and I would love to be able to see virus load measured.
So whether or not that can be checked on the samples that are being collected, I think everybody's getting serum, they're getting plasma.
Yeah, not good.
Yeah, that's what
tricky. Yeah.
Question,
okay.
How are you going to ascertain in the prospective studies that VTE, DVT occurs? We have these ongoing collaborations with our pulmonary care critical doctors in the ICU who feel that some of these early studies were done in patient efforts, so everything is retrospective, or most of it is retrospective. And then in these early studies, they were sort of symptomatic in some fashion, and based on that, some studies were done, and then you get these really higher 40% VTE cases, which they swear are also present in other viral illnesses and are nothing special about COVID. So from our pulmonary critical care doctors, also dissect that literature, we get a lot of pushback, especially in terms of when to test for VTE. So is it certain ventilator settings? What prompts in these COVID patients to actually check for symptoms? And so, or for VTE based on symptoms. So I just wonder, how are you constructing these trials too? It is so important to have prospective randomized trials now, because otherwise we will just never get to that question.
Right. So the two outpatient trials are both driven by symptomatic manifestations. Somebody goes to their doctor, they've got symptoms, they get tested, and that's how it gets identified. Both of the outpatient trials, everything is independently adjudicated also to confirm that a thromboembolic event of some kind occurred. For the inpatient study, there's no restriction saying that you have to have certain symptoms before you get screened. They are not, again, they're not doing standard routine screening of these individuals. It's symptom driven, but it's recognized that the symptoms could be variable depending on the place where you're at. Yes. Here it's our CT anesthesiology people who really are driving this, and wanted actually at our institution everybody to be on therapeutic anticoagulants before COVID even started. And I had to step in and actually design an algorithm that would allow them to go to one of these accelerated thromboprophylactic strategies. And at our place, probably about 4 or 5 of the people could not get transferred down to a scanner. They were too sick to go. So we did have people who were considered clinical diagnosis of PE. But again, it's kind of driven by your program and who's running the ICU, because they're the ones who are often making these decisions. You can help with guidance, but
I think the interpretation of these studies is just so difficult based on what you just mentioned, criteria for diagnosing VTE, DVT, hospital dependent, so intermixed, all this literature, unclear how much coagulation people actually got while they developed or didn't develop any symptoms. And it's really confusing. So I hope that this prospective, these will bring some clarity.
yeah, I think it's going to be good data that we get out of these.
So Annette, if I can comment, the inpatient trial, the primary endpoint is not thrombosis. It's 21 day, it's the number of organ support free days over 21 days. So it's a like semi-continuous variable. It sort of almost turns out to be like a binary variable, because either you get transferred to the ICU or you're not, or you're in the ICU longer, which is the driver of the organ support, which is, you know, ventilator support and pressures. And so the VTE are a secondary outcome, and they will be adjudicated. And the protocol talks about, you know, guidance for detecting them if there's sudden respiratory compromise, for example.
I think that makes sense. It's almost like a surrogate parameter, because it is really difficult to diagnose VTE in COVID in the ICU. So that's kind of a surrogate, feet up, feet down, which is probably the best.
And I think, you know, really the intent of the inpatient study is to hasten the recovery. It's not to prevent thrombosis. It's very different from Tom's trial, which is more like a VTE prevention trial, whereas the inpatient study and the pre-hospital study are more about, you know, preventing that thromboinflammatory progression that leads to organ failure.
I'm going to jump in. I'm going to jump in here because we could talk about this all night, and we have a few more presentations. So Tom, thank you so much. Thanks, Mary, for jumping in there. It's having all our speakers, for that matter. Hey, you'll have to hold that question. All right. Send your notes to Tom and to Mary and to others, and we're going to take a break.